Today, I want to answer the question of, does this patient have ITP? Now, usually, this question comes to me when the patient presents with severe thrombocytopenia and people have looked at the blood film, they don't see any red cell fragments or schistocytes. They've looked for hemolysis markers. There's no evidence of hemolysis. And they were like, well, it's a pretty low platelet count. Is this ITP? That's a really great question, and we should answer that. All right, how do you know the patient has ITP? I'll tell you the short answer and the long answer. The long answer is that ITP is actually a diagnosis of exclusion. That means after you've tried to figure out every other possible cause of thrombocytopenia and you haven't found it, then you can feel confident that it's probably immune thrombocytopenia. That means you really have to do a thorough workup to exclude all of the possible causes of thrombocytopenia. And I will tell you that is a really serious workup as well. All right, what does that workup look like? Number one, you want to exclude infection, right? So there are viral infections that could cause immune thrombocytopenia, some of them notably being hepatitis B or C, some of them being HIV, CMV can also cause it, that's cytomegalovirus, and also Epstein-Barr virus could cause thrombocytopenia as well. So one of the things you will do early on is to rule out viral etiologies of thrombocytopenia. You'll also want to rule out infection in general. So if a patient is septic, if they have a pretty major bacterial infection going on, that could be a cause of severe thrombocytopenia as well. So those are the things you want to do. You do want to rule out infection. The next thing you want to do is rule out systemic causes of thrombocytopenia. So there are other systemic diseases that could also precipitate thrombocytopenia. So for one, if the patient has cirrhosis and they have portal hypertension, they're going to have thrombocytopenia, usually not to the level of severe thrombocytopenia, but they're definitely going to have thrombocytopenia as part of their underlying disease. So you do want to clarify what is underlying. Do they have autoimmune disorders like lupus that may explain thrombocytopenia? Do they have a history of antiphospholipid antibody syndrome that may explain the thrombocytopenia? So you really want to do a good, thorough search of what are some of the underlying systemic illnesses that could be precipitating thrombocytopenia. Okay. Another thing you want to do is you want to rule out hepatic disease. And so you do want to make sure you have a comprehensive metabolic panel that tells you about the AST and the ALT, but you might also want to do an abdominal exam. Actually, you don't might, you should do an abdominal exam to look to see if there's splenomegaly or even hepatomegaly. Many times we will go to imaging and we'll do an abdominal ultrasound to take a look at both the liver and the spleen as well. Many times presentation with thrombocytopenia was the very first indication that a patient had cirrhosis, or the very first indication that a patient had fatty liver, or some other etiology that was not previously diagnosed. So you definitely want to look for systemic causes, and you want to look at the liver and the spleen and make sure that they're appropriately sized. All right, another question you want to answer is, has there been an acute thrombosis? So sometimes if you have massive thrombosis, it consumes the platelets. And so you want to check to make sure that there is no concern for a deep venous thrombosis or a pulmonary embolism. Another thing that you want to ask along the line of systemic illnesses is, does the patient have disseminated intravascular coagulation? So usually in this syndrome, it's a consumptive coagulopathy and the platelets are low. So you do want to look at the fibrinogen, you want to look at D-dimer, fibrin degradation products to get a sense of whether DIC is present or not. And then you also want to make sure that you're not missing a nutritional deficiency. And so you would check for B12 and folate, methylmalonic acid levels, so that you can make sure it's not a functional B12 deficiency. And sometimes, depending on if they have anemia as well, you could consider whether you send a copper level as well. But you send all these testing to make sure that you're not missing a nutritional component causing thrombocytopenia. Though usually those don't drop your platelets very low, but they do help if you have them on board because they'll help the platelets come back up as well. All right, we've talked about infection, we've talked about systemic illnesses, and we've talked about the possibility that there's hepatomegaly or splenomegaly. What's left? You also want to make sure that there's no known blood disease or no known malignancy. So for example, is there myeloma? Is there an evolving myelodysplastic syndrome or an evolving leukemia? Those are the things that potentially you might get a sense of from looking at the differential or looking at the blood film under the microscope. Remember, they always do that. If there's thrombocytopenia, if there's any cytopenia, in fact, any cytosis, you really want to look under the microscope. And so that would give you a sense of whether there is any particular reason why you should suspect a hematologic malignancy. All right, so that's that. And then you also want to make sure that you are not missing a medication cause of thrombocytopenia. So you want to evaluate the medication history, look to see if there are any antibiotics that could cause a drug-associated thrombocytopenia. This is where you want to make sure that heparin is not on the list of medication that the patient is taking, because it could be a thrombocytopenia related to heparin. So you definitely want to make sure that you are not missing that. All right. And so there's a whole slew of tests that you're going to order to satisfy yourself that there is no other potential cause of thrombocytopenia. And then you could feel confident in saying that it is probably an immune thrombocytopenia. All right, that was the long answer. The short answer is that, yes, you're still going to do the workup, but sometimes when you look at a patient and their platelets are severely less than 10, and they definitely don't have a TMA or thrombotic microangiopathy or microangiopathic hemolytic anemia, it's likely that they have an immune thrombocytopenia. If platelets are much less than 10,000, it's so much more likely that it's an immune thrombocytopenia, because there are very few things that will take the platelets that low. That being said, you would still want to make sure that you evaluate for all other causes, because some of these infections can cause an immune thrombocytopenia. Some of these systemic illnesses can cause an immune thrombocytopenia. So you're really trying to distinguish between whether it's a primary immune thrombocytopenia, idiopathic, or whether it's secondary to something else that's underlying. So it's not so straightforward, but you do want to make sure you do a thorough workup to evaluate for other potential causes before you settle on a diagnosis of immune thrombocytopenia. Ultimately, if they're not bleeding, they're otherwise stable, we would move to treat at platelet counts usually less than 20 to 30,000. And one of the ways in which you kind of get a sense of whether you are correct at or not was in how your platelets respond to therapy as well, though that's not always absolute. So by this point, you really should be talking with your hematologist. All right, that's all I have to tell you about making the diagnosis of immune thrombocytopenia. Thank you for spending this time with me. I'll see you next time.